Hi, my name is Jeanette Domask, and I'm a risk manager with OMIC. Topic today is lessons learned from glaucoma claims, closing the loop, medical record amendments, and co-management guidance. So the learning objectives of this talk is to understand medical record documentation amendments, to implement safety protocols, to close the loop on referral and test recommendations, and to define roles and responsibilities of the healthcare team, including licensed and unlicensed staff. So this includes co-management with optometrists. So first I'm going to go over some claim statistics. Open claims that OMIC has as of January 1st, 2025, and this includes claims and lawsuits. We have a total of 431, and as you can see, the majority come from cataract and retina, and this is historically the case where most of our cases come from those two subspecialties. Open claims by state. Our top 5 states are California, New York, Pennsylvania, Florida, and Louisiana. This is also where we have large volume of insureds, and they are more litigious venues as well. Average indemnity payments. This slide shows that since 2011, as you can see, the indemnity payments have been going up and down, but last year they increased quite a bit, and the average indemnity was $400,000, approximately, just under $400,000. This slide shows our largest settlements, top 10 largest settlements in OMIC's history, and the highlighted glaucoma cases is the reason that we chose to focus on glaucoma claims, because they have resulted in significant settlement in cases that we've had. So the way this presentation is designed is we'll discuss actual OMIC cases, discuss the chronology, and then talk about what happened during litigation. And then from the case, we'll discuss risk management takeaways and make some recommendations to mitigate risks and improve patient safety in your practice. So this first case, involved a patient with chronic uveitis. So this was a 32-year-old patient, had treated for 9 years for resolved intermediate uveitis. She was treated with topical steroid and Kenalog injections. She had posterior subcapsular cataracts. Intermittently, she had elevated pressures, and then she was also a type 2 diabetic with uncontrolled diabetes. She had been taking medication, Predforte, long-term, and then most recently was prescribed Timolol. So in December, she came to the ophthalmologist's office and complained, "I believe my vision is worsening." The best corrected visual acuity was 20/20. Her pressures were 35 and 32. The physician's impression was possibly due to steroid response. The plan was to add the Timolol every morning and then change the Predforte to 4 times a day, and then follow up in 4 weeks with a pressure check. So the patient returned in 4 weeks, or no, actually the patient returned 7 weeks later instead of 4 weeks. She complained of blurry vision, right greater than left, and then she said that a month prior she had a black cloud over her vision on the right eye, and it lasted for an hour. She said it went away, but then it returned last week and it was still there. So the exam revealed that her best corrected visual acuity on the right was 20/70, so it had decreased, and her pressure on the right was 38, and it was tested 3 times. So this time the physician's impression was the vision loss was due to cataracts, and he was going to monitor the progression and wanted to increase the Timolol. So the patient returned March 7th, and her pressure was still 35 on the right. The plan was to stop the Timolol and to add Costop and bromonidine 3 times a day, and then to return in 10 days. The patient returned, her vision was stable, and the pressure was down in the right eye, but the cup to disc ratio was increasing, and the documentation said referral to a glaucoma specialist. Patient returned May 2nd. She complained she could no longer see out of her right eye. The cup to disc ratio had increased. The diagnosis was primary open-angle glaucoma, severe in the right, likely responsible for the vision, and the physician added medications, and the plan was to refer to a glaucoma specialist as soon as possible. Patient presented to a glaucoma specialist on May 5th. Her vision was hand motions, her pressure was 35. She was diagnosed with inflammatory open-angle glaucoma and also had a posterior vitreous detachment on the right. The plan was a tube shunt, and that was performed 5 days later. The patient's remained light perception on the right. So the patient ended up filing a lawsuit against this physician for failure to timely refer her to a glaucoma specialist due to the elevated pressures. The damages, patient never recovered vision and remained light perception in the right eye, and claimed difficulties with activities of daily living. So during discovery, when the physician was deposed, the physician said he recalled telling the patient in March that a referral would be made to the glaucoma specialist and the staff would follow up. It's unclear exactly what happened, if he ever told the staff or if the staff didn't follow up, but the referral wasn't made until 2 months later. So subsequently, the referral plan was inserted into the March visit note several months later. And this was discovered because the patient's record request was made prior to litigation, and it produced records that did not show documentation regarding a referral to a glaucoma specialist. And it also revealed there were differences in pressure readings when compared to the insured's records produced during litigation. So there were 2 versions of the medical record. One was when the patient made a record request prior to litigation, and then there was a different version after litigation was filed. So OMIC reviewer felt the long course of steroids was likely below the standard of care due to the elevated pressures and no testing. More aggressive treatment needed to be done in November, December, and clearly there were documentation issues in the electronic medical record. Some notes were signed off 6 to 8 months later. The records were altered with the referral note inserted and with the pressures changed. So in this case, the insured consented to an early resolution because it was difficult to defend a case with record alterations, and the case settled for a significant amount, for $2 million. So from a risk management perspective, in litigation, 86% of glaucoma claims that resulted in this settlement included one of these allegations: either a failure or delay in diagnosis, improper management of the treatment plan, including delayed referral to a glaucoma specialist, improper performance of surgery, and improper management of surgical patients. So from a risk perspective, it's really important to implement a protocol to close the loop. And that involves identifying any gaps or weaknesses in the process of referring a patient to a specialist or an outside consultant, or referring a patient for testing, referring a patient for labs. It's important to close the loop and follow up and make sure those items were followed through with. And yes, this is a lot of work. Unfortunately, in litigation, there is a lot of the physician is considered the expert, the patient the layperson, so the patient isn't necessarily given as much responsibility, even though they're told you need to follow up, you need to get this referral, you need to get this testing. It's really important to just have some process in place to make sure that those recommendations don't slip through the cracks. It's also important to make sure the patient understands why you're making those recommendations, why you're telling them they need to go seek a referral, or why they need to get testing, provide education, uh, make sure if they refuse, have them sign an informed refusal so it's very clear that you explain the risks to them. Can use the electronic health record to track, to try to close the loop. And, it might just be involving running reports on outstanding labs or tests or referrals that have not been submitted. Make sure the team's aware of policies and procedures to improve patient safety, and then make sure you audit this process when you implement a protocol to close the loop. So as a follow-up strategy, it's important to make sure that you explain why you're recommending this information to the patient, or why you're recommending referrals or testing, so that they comply, and document that you told them this. They have a risk of losing vision if they don't follow up with your recommendations. Describe those consequences, document this discussion, implement those tracking systems, and then establish those policies and procedures to close the loop, and then develop goals to ensure timely diagnosis and treatment. And then as last resort, terminate the patient if they're not following your recommendations. They make it very hard for you to treat them if they're not going to comply with what you're recommending. And they can create liability exposures if you continue to treat them and they're not following your recommendations. So late sign-offs in the medical record. So late sign-offs really speak to the credibility of the medical record. The medical record is a legal document, so it's really important that records are signed off in a timely manner. If they're not, that can lead to incorrect diagnosis. If records are sent out and the record's not complete, it can lead to delay in treatment and referrals, medication errors, inappropriate treatment plans. It can also create a litigation risk. The late entries can cause credibility of the entire medical record. So the credibility of the physician and of the record comes into question during litigation. And these cases are difficult to defend. In litigation, they do retain forensic experts to look at audit trails to see when records were changed. And so in that case, there was it was an electronic medical record, and the audit trail was able to show that the record was altered. So you want to make sure that there is some way to follow up and review documentation, have a protocol and policy in place for when records should be finalized. They should be completed, as soon as possible, but there should be, if 72 hours sign off and finalize, or whatever your policy is internally. Sometimes at the end of each day is not possible, but it should be as close to the actual visit as possible. And then use the EHR features. That is possible to run a report to see open records that haven't been signed off on, and how long they've been open, to try to get compliance among the healthcare providers to sign off on their records. If you use a scribe, ultimately the physician remains responsible for all documentation, even if a scribe assisted. So prior to finalizing and signing off, it's important that you review for accuracy and thoroughness, just like you would with your own notes, and provide regular feedback to the scribe. This is also true if you use AI. Some practices have started to use AI for documentation purposes, so it's important to be able to, you need to review the documentation before finalizing and signing off, because that AI can have errors as well. And record amendments. So in litigation, medical record scrutiny in both paper and electronic is something that the plaintiff attorney does focus on. If they see that there's any chance that their record was altered, they will focus on that. They'll get handwriting experts, they'll get forensic experts to look at the audit trails. And record alterations cannot be defended. Additionally, most insurance carriers will not continue to insure a physician that alters the medical record. So it's really important if you're making amendments to have policy in place for when amendments can be made. So these changes can be legitimate and they can be done correctly to avoid appearance that the change was intended to conceal or falsify what occurred, but they should occur infrequently. So there should be a process in place depending on if you're making late entries or corrections or addendums. Every EHR is different, and so every organization should have a policy in place for what is considered the right policy or right procedure for making an addendum or a late entry. So an addendum is an entry added to the health record to provide additional information in conjunction with the previous entry. So the previous entry should remain as it was at the time. The addendum then is added, it should be usually titled addendum, and it'll have, if it's an electronic record, it'll have a time and date stamp, and then why you're making the addendum. Often you see this in radiology reports. A radiologist will have an initial interpretation, and sometimes they get additional information later on, and they're advised that their original interpretation wasn't accurate. So they don't go in and change their original interpretation. They just add an addendum and then put in the new information and date and time stamp it. And that's the proper way to do an addendum, even in non-radiology reports. Corrections, it's a change in the information meant to clarify inaccuracies. So there should be a process on how you're going to make corrections in the medical record. Changing something, there's always versions that are created. So if you change something in the record and don't make a note that you did it at a different date, that can lead to credibility issues because, again, there's going to be two versions behind the scenes of what was originally written. So it's better just to do an addendum. Deletion, that's usually not allowed in EHRs. And then late entries, those are similar to addendums. That's when pertinent information wasn't written in a timely manner and should be added to clarify the record. And a late entry should never be done when you receive notification of a lawsuit. That's oftentimes when physicians have will alter records is when they receive a lawsuit and then they panic and they add things to the record. So nothing should be added, no addendums, no late entries if you receive a notification of litigation. So other reasons they might be necessary: the note wasn't complete, there was some omitted information, there was insufficient detail in the medical record, or there's documentation errors. So it's really important, if you do need to make an amendment, you understand how to do so correctly, follow the organization's policies and procedures, or make sure there are policies and procedures established, and then contact risk management for assistance. So the second case is an emergent referral for Topamax-induced angioclosure glaucoma. In this case, a 35-year-old presented to a neurologist with a 3-month history of migraines and was prescribed Topamax. The patient reported to the neurologist that she awoke with severe vision loss after double dosing on topiramate the day before, then developed severe headache, nausea, and vomiting. The neurologist called an ophthalmologist office and requested the patient be seen that day for suspected topiramate-induced glaucoma. The patient was scheduled as a work-in at 3:15 for blurry vision. Later that day, the patient arrived at 3 but wasn't brought into the exam room until 4:50. The technician dilated the patient. The physician attempted to do a complete exam but was unable to due to pain and discomfort and photophobia. Mild injection of the conjunctiva and the corneal edema bilaterally. The anterior chamber was shallow in the periphery, and the visual acuity was counting fingers at 1 foot bilaterally. So the treatment was medications. Glaucoma meds were given at 4:58 and 6:30. No steroids were administered. The results at 6:49 were pressures were still elevated at 49 and 52. The impression was acute glaucoma, malignant glaucoma versus angle closure glaucoma. And the plan was that the physician called a glaucoma specialist who agreed to see the patient the next morning at 11:30. Patient was seen the next morning at 11:30 by the glaucoma specialist. Her pressures were still elevated at 44 and 46. Impression was angle closure, history of topiramate use, and then laser iridotomy was recommended and performed later that day. Ongoing care, the patient continued with the glaucoma specialist. A year later, her vision was relatively stable. Her cup to disc ratio 2 years later had increased, and the pressures remained stable. And then it was discovered the initial note was altered by the physician when the patient requested a copy of the medical records approximately 1 year after the event. So the patient filed a lawsuit and alleged delayed treatment of the glaucoma and failure to lower the pressures in a timely manner, resulting in optic nerve damage and decreased central and peripheral vision. An IME was performed. The patient had severe peripheral and central vision loss. The retained experts felt that the delay in seeing the patient 2 hours after the appointment was below the standard of care. The physician failed to diagnose the topiramate-induced glaucoma, failed to stop the topiramate and start cycloplegics and atropine and steroids to address the corneal edema and presumed choroidal swelling, and that it was below the standard of care to send the patient home with elevated pressures and no appointment until 15 hours later. They felt the patient should have been sent to the ER for IV medication. And finally, the alteration of the medical records were indefensible. And again, this case settled for a greater amount because of the altered medical records. It settled for $450,000. And this case highlights record alterations. So the prior case illustrated the risk of improper late entry in the medical record, while this case illustrates the risk of late and improper change to the medical record. So an improperly executed change to the record that is made in close proximity to the medical record request and a long time after the event in question will definitely raise suspicions about the motivation for the change and its credibility. So we suggest you pause if you need to make an amendment in the record before producing a copy of your medical records. Speak with someone, speak with risk management or your practice attorney. It's really important not to make changes or late entries in the medical record. It does make these cases very difficult to defend. Another topic that this case brought up was telephone screening by unlicensed staff. So in this case, the role of unlicensed staff is limited to gathering and transmitting information and assigning an appointment category. So in this case, the scheduler just didn't document that the neurologist is the one that called. The neurologist felt that the patient had topiramate-induced glaucoma. That wasn't documented. It was just documented that the patient had blurry vision. So really the urgency wasn't documented very well. Um, the unlicensed staff, if they take calls, cannot engage in independent medical decision or interpretation. They can't offer medical opinions on the cause or symptoms. So telephone screening by unlicensed staff, sometimes it can lead to misinterpretation, like inadequate documentation, and misinterpretation of the patient information that can lead to legal liabilities if the patient's condition worsens. Plaintiff may allege that the screening calls without policies and procedures and physician supervision is the unlicensed practice of medicine. So it's really important to develop telephone screening policies and procedures. Now, telephone triage has to do with clinical nurses. This is just non-licensed screening. So you want to create a policy for handling post-op complaints, policy for patients who want to be seen as soon as possible, physician referrals. Is it emergent? Is it urgent? Is it non-urgent? Have a workflow in place so that it's known how to handle them when they come to the office. Protocol for missed appointments and no-shows, and it's important to document those and to have some kind of follow-up system. And then when physicians want to be interrupted, if there is urgency with the calls. So it's really important to have physician approved written policies and procedures, have a workflow. We have an example to show, but to have a workflow and elicit the information from the patient. Sometimes patients can just give vague information, so you want to train staff to elicit the information from them so they're a little more detailed, and have a way for the staff to report any challenges or concerns that they encounter with the screening, and then have ongoing training and supervision of the non-licensed staff. So this is a sample telephone screening form. This is something that can be templated electronically, and you can have drop downs, so it could be easier. If you answer this, then you get this question. But there's ways to make it a little more brief. But the key is just that the staff has questionnaire to follow when there is concern, so they know how to best manage either having an appointment right away or scheduling an appointment later on. This is an example of a procedure, based on the complaints the patient has, whether and what conditions would be considered emergent, what conditions are urgent, and what is routine, so that the staff member can best identify whether the patient needs to be seen right away or can be seen at a later date. The third and final case is a delay in diagnosis of glaucoma in a co-managed patient. So in this case, this was a patient who had a medical history of high blood pressure, heart attack, cardiac stents, thyroid disease, and bilateral cataracts. This patient was established for 10 years, starting at age 63. Since 2012, she was treated by physicians and optometrists for dry eyes. She had various treatments, topical tears, cyclosporin, punctal plugs, antibiotics, steroids, and IPL therapy. She did have a sibling with glaucoma. The optomaps were performed annually to assess the back of the eye, and care was provided by 2 ophthalmologists and 1 optometrist in the same practice. So this was an older case. We used this case to highlight some of the risk management issues that came up. This was in August of 2013. Patient presented. She had cataract surgery on the right, and then presented again in September, had cataract surgery on the left. She immediately postoperatively complained of blurry vision in both eyes, more in the left with pain. She returned in October and continued to complain of blurriness, like a layer of plastic over her eyes and dry eyes. She had an abnormal Amsler grid. No visual field testing was completed. In December, she felt her dry eyes were worse. In January, piggyback lenses were placed. And in March, the pressure spiked to 32 on the left, and she was assessed with borderline glaucoma with a steroid response. And then in July, she complained of dryness, burning, tearing, sandy, and grittiness. Bilaterally with continued floaters on the right. Visual field testing was done. She returned in July. Her cup to disc ratio was increasing. There was an OCT of the optic nerves, and at this point she was diagnosed with normal tension glaucoma, the left greater than the right, which was exacerbated by the pigment dispersion from the piggyback lens on the left and the long-term steroid use. In August, 2 stents were placed bilaterally, and the piggyback lens on the left was removed. The glaucoma remained stable. In June of 2015, the patient presented for her last visit, and she was diagnosed with glaucoma secondary to other eye disorders. Her left eye of severe stage was due to the long-standing history of steroid use. So the patient filed a lawsuit against the 2 ophthalmologists and the 1 optometrist in the practice. She alleged a delay in diagnosis of low tension glaucoma, alleged improperly implanted piggyback lens and a delay in removal, alleged improper refill of medications by staff with no physician oversight, and there was a failure to discontinue the steroids, which led to the glaucoma, and then a failure to perform optic nerve exams, relied only on the optomaps instead. So the claimed damages were light sensitivity, decreased depth perception resulting in tripping and falling, and assistance with activities of daily living needed. So the retained experts all felt that the care was below the standard of care. The evidence of developing glaucoma several years before the diagnosis required visual field studies that weren't done. There was a failure to monitor for the glaucoma and changes to the optic nerves. The physician allowed the optometrist to perform optomaps in place of comprehensive eye exams with evaluation of the optic nerve. There was concerning changes in the optomaps that weren't addressed. Non-physician staff was authorizing refills after physicians had tapered and stopped steroids. They had actually changed from a paper charts to electronic charts, and the information of the physicians stopping the steroids didn't make it to the electronic chart, so there was confusion and poor documentation concerning the refills. There was a late diagnosis that resulted in additional procedures that caused the condition to worsen. In this case, settled for 162.5. Again, this was 10 years ago. And 60% was attributed to the practice for system failures, including the optometrist's liability, and then 40% was attributed to the physicians. So from a risk management perspective, there were some issues that came up in this case, including co-management. So the co-management issues were lack of communication between the MDs and the ODs, lack of physician oversight of the OD provider, and then lack of recognition of early glaucoma. There was a failure to diagnose, failure of the optometrist to do the optic nerve exams and follow the patient closely, failure to interpret studies, failure to conduct proper tests to monitor the patient, and failure to diagnose. There was also a lack of medication refill protocol. The refills were provided without physician authorization. The refills were also provided for medications that were previously stopped or limited. There was no medical record reconciliation performed, and not all refills were actually documented. So for co-management, the risks, again, are miscommunication, delay in diagnosis, med errors, difficulty seeing patterns, system patterns, and progression of disease, care coordination with other specialists, and then patient confusion regarding the treatment plan. So OMIC does recommend that practices that work with optometrists, whether they're employees, independent contractors, or participants of a call group, have a written protocol. It's important that the protocol includes roles during office hours, roles during after office hours, emergency department call, and any ophthalmologist backup. And then all members of the practice should be allowed to review and comment on the proposed protocol before it's adopted. And then once implemented, the protocol should be reviewed and updated on a regular basis, including initial and ongoing training for staff. And also the optometrists, their education, licensure, certification should all be vetted before getting into co-management agreements with optometrists, should understand state laws regarding optometrist scope of practice, define the role of optometrists when managing different categories of patients, independently within the scope of practice, patients that require consultation with an ophthalmologist. So there should be criteria for when the patient should then be referred to the ophthalmologist, patients that might need to be managed by an ophthalmologist, and set expectations regarding documentation and sharing of that documentation. If they're in the same practice, obviously you can get that information, but sometimes if they're in a different practice, how do you share that information, get that information to the co-managing physician, and then or optometrist, and then establish the protocols for communication between optometrists and ophthalmologists. And then prescription refill, the problem was that non-physician staff was approving refills, and I've seen EMRs that have this set up where if the refills are ordered, they just automatically go out to the pharmacy and they don't go to the physician. And in this case, that was what was done, but the physician had stopped the refill, so there was an issue in the EMR allowing those refills to go out, and not all the prescriptions were actually recorded in the medical record, and this might have been in the paper when it was still a paper chart. So there was not a clear description of roles, responsibilities, and steps for new and renewed prescriptions, and a lack of physician review prior to submitting the prescription. So it's important to have a prescription refill protocol to document the number of refills allowed before a patient must return for a follow-up appointment, the staff role in handling refill requests. This is also outlined in scope of practice in your respective state, outline steps for obtaining physician authorizations for refills and new prescriptions, how to transmit the order to the pharmacy, how to document the transaction in the medical record, how to communicate to patients that a refill or a new prescription has been denied until the patient comes in for a visit, how to document that communication, and then explain your prescription refill policy to patients. Make sure that they know that after a certain amount of time, they will have to return for an exam before you refill their prescription. So in closing, it's important to train all staff on policies and procedures, set expectations, ensure compliance and patient safety, develop policies and procedures for telephone screening for non-clinical staff and for co-management with other providers, audit to confirm compliance with the protocols or to discover improvement opportunities, develop policies and procedures for guidance concerning amendments to the medical record, and develop policies and procedures to close the loop on ordered labs, tests, and referrals. And on omic.com, we do have resources, including documentation of ophthalmic care, coordinating care with optometrists, co-management of surgical patients, telephone screening toolkit, non-compliance toolkit, terminating the physician-patient relationship toolkit, and the AHRQ has some information on improving lab testing processes. healthit.gov has information on test results reporting and follow-up. The Institute for Healthcare Improvement, IHI.org, has resources on closing the loop. And then the American Health Information Management Association, so AHIMA.org, has a nice toolkit on amendments in the health record, the electronic health record, and things to consider when you're establishing policies and procedures for amendments to the electronic health record. So these are our online resources. resources, and this is how you can contact us, and we appreciate your time and attention listening to our presentation. Thank you.